Welcome to our
us?
presentation of the Flemish cervical cancer screening program. My name is Eliane Kellen from the Centre of Cancer Detection. We have nothing to declare. Prior to 2013, screening was essentially opportunistic in Belgium, which means that pap smears were taken at the spontaneous initiative of the woman, her gynecologist, or her general practitioner. Thus, screening was and is still based on a 3-yearly cytology for women aged between 25 and 64 years old. In June 2013, an organised screening program was set up in the Flemish region. The program is financed by the Flemish government. A call-recall system has been developed whereby only women are invited who are due for screening. Women recently screened are therefore not invited. The screening program uses a centralized invitation procedure. All invitation letters are sent by the Centre for Cancer Detection. The target population is identified from the Central Population Registry of Flanders. The national security number, a unique 11-digit personal identification number, is used to cross-link the population registry with the data collected by the Belgian Cancer Registry.
So my name is A.Haelens. I'm working at the Belgian Cancer Registry, and we thank the organizers to give us the opportunity to present our presentation here about the cervical cancer screening in Flanders. So how is screening organized? On the one hand, there is the Belgian Cancer Registry. Beside the cancer database, we have a central cytohistopathology registry with all the results of the cervical samples which are delivered by the laboratories. This registry includes cytology, HPV results, and also the histological results. The database is supplemented with the reimbursement data of medical acts that are relevant for cervical pathology. We also receive from the insurance companies identification of the general practitioner who manage the centralized medical file of the woman or the target population. This is a GMD GP. Through this centralization of the data, BCR can support the screening organization in a very efficient way by means of exclusion lists, fail-safe lists. And in addition, BCR is also involved in quality assessment, research on the tumor characteristics, and the evaluation of the laboratories. Due to this close collaboration with the Centre for Cancer Detection, which involves an intensive exchange of data in accordance to the General Data Protection Regulation, CERVICAL can collect all information regarding to participation, fail-safe, and the GPs. So CERVICAL sends invitation letters, fail-safe notification to doctors, and is responsible for sensibilisation and also quality assessment. The date of the last screening and the next invitation are made available at the electronic VitaLink platform that can be consulted by the woman. VitaLink is a free online health platform to share medical information between civilians and their medical professionals, also about vaccination and medication schemes.
The target population in Flanders are about 1.7 million women. This is a mix between women who are diagnosed with cancer. Some women had a hysterectomy and some had a recent pap smear. Some women are never screened before. A pap smear can be taken either on a woman's own initiative, as a response to a letter, or as a medical follow-up. So, who should be screened? After linking the databases, BCR sends 4 times a year an exclusion list containing for each woman her eligibility for the screening and invitation program and the date of the last pap smear. In this way, women can be invited in a targeted and very cost-efficient way. About 6% of the target population is excluded forever due to a cancer or hysterectomy, and they will never receive a letter anymore. About 42% of the women are temporarily excluded because they had a recent pap smear, so they will not receive a letter either. That leaves about 51% of the women eligible for invitation. 48 months after the last pap smear, An invitation letter is sent to encourage women to book an appointment with a doctor of choice to have a pap smear taken. Women who do not respond will receive a subsequent letter after 36 months. Women who actively opt out will not receive a letter either. Once a year, a sensibilisation list of all eligible women who do not have a who never had a pap smear taken is made up. I will come back to this later in the presentation.
An important indicator is a screening coverage, which is monitored in detail. In 2020, 6% of the target population was covered by exclusion due to the removal of the cervix or an invasive tumor in the past. 43% had a recent participation, and 51% of the population should have been screened in 2020. Part of these women receive an invitation letter, and the response rate to this letter is 22%, meaning that 22% of the women who received a letter all indeed had a smear 12 months after the invitation. 40% of the women belong to the eligible population and were screened in 2020. For about 1%, it was the first time ever. And this results in a total coverage of 63%. 25% of the population was not covered in 2020, but had at least one old participation more than 3 years ago, and 30% was not screened. The temporarily excluded women participating in 2020 are a mix of follow-up and overscreening, and about 5% of the total population is overscreened.
A worrisome trend is the decline of coverage in the youngest age group, women between 25 and 29. In 2013, 64.8% of these women were adequately screened. This number decreased to 59.8% in 2020. We have no explanation for this observation. A hypothesis might be that women believe that once they are vaccinated, screening is not necessary anymore. The school-based vaccination program started in 2010. However, vaccines were available on prescription prior to 2010. The interactive website Bevolkingsonderzoek in cijfers show the coverage on different geographical levels and different time periods. For example, we show here the Flemish provinces and the province of Antwerp. Then we show the coverage in the city of Antwerp. The coverage in the different neighborhoods in the city of Antwerp. This enables local partners such as NGOs and municipalities to organize a very local sensibilization campaign. So who does not participate? We investigated the socioeconomic and demographic profile of non-attenders. The screening database was linked on an individual level to the one of the crossroads for Social Security, using the National Security Number. We found that women in poverty participate less. Poverty was measured by 3 proxy indicators: being entitled to a higher reimbursement, not having a paid job, and a low level of work intensity on household level. We also find that women from immigrant women do not participate less, and especially women from Eastern European origin. Finally, the results indicated that women with a disability also participate less. Once a year, a list of all eligible women who never had a pap smear taken is made up by the Belgian Cancer Registry. The Belgian Privacy Commission approved the request to send tailored communication material to these women. We set up an RCT, and the women in the intervention arms are randomized to receiving an adapted letter or leaflet using a narrative writing style, or to receiving the regular letter in an envelope without a window, as a window envelope might be received as one for an invoice. And for the women randomized to the third intervention arm, we sent an electronic message to their GP. For the study targeting women above 50, we can present already some results. We analyzed after 12 months after the intervention the proportion of women who had a pap smear taken. Nearly 3% of the women who did not receive any intervention at all had a pap smear taken. For the other interventions, the proportion is between 4 and 5%. Although the results may be disappointing, we proved that adapting the content of a letter or leaflet has a very limited impact, and other interventions are needed to reach never screened women. Through a community-based 7-step project, we aim to involve local authorities and partners to reduce barriers in the screening. The first step is to create support among local policymakers. Subsequently, the participation stratified by age groups is studied in local districts and neighborhoods. The target population is determined, reasons for non-participation are listed, and this leads to the identification of priorities and objectives. Actions are made concrete. Who does what when and which resources are needed. Evaluation should also include local policymakers. And finally, it is important that valuable insights will not be lost and local actions are integrated in the local policymaking plan on a long-term basis.
Now we will continue with the screening results of all screening smears taken from eligible women into 2020. 8% was abnormal. If we further subdivide all abnormal smears according to the lesion, ASCUS is the most frequent with 56%, followed by the L-cells, it's 26%. 5% is H-cell and 4% ASC-H and 4% AGLC. This slide shows the trend in incidence in Flanders between 1999 and 2019 for all ages and the screening target age. Both the incidence of the invasive tumors and the mortality seem to decrease very slightly, in contrast to the incidence of the in situ tumors, which is 6-fold higher in 2019 compared to 1999. If you look at the age-specific incidence over 5 periods of 4 years, we see that for the invasive tumors, for the earliest period, a plateau was reached at the age of 35. It remains high, but for the most recent period, the peak is only at age 40 and remains lower. For the in situ tumors, it appears that the peak is between 25 and 39 years of age. It increases and shifts slightly to the left. Below the age of 25, the increase seemed to be slowed down in the recent years, which might be explained by vaccination, but also by the lower screening coverage. We don't know exactly the reason. This figure shows a stage distribution of invasive tumors in the target population. But there appears to be a large difference in the stage distribution after splitting according to the screening profile of the woman. For the screened woman, about 68% of the tumors is stage 1 and only 7% stage 4. If you look at a never screened woman, more tumors are seen in the more advanced stage. It's 70% stage 4 and only 41% in stage 1. Now, the follow-up rate for the lesions between 2015 and 2019, the follow-up rate of the abnormal screening smears fluctuates around 8%, but it varies strongly depending on the diagnosis and the corresponding HPV result, as you see on the slide. The more serious lesions have a better follow-up rate in contrast to the less serious lesions for which it is lower. To improve the follow-up rate, a fail-safe system was set up in 2018. Now, in 2018, the fail-safe system was set up and evaluated last year. Now, in 2019, 270 women were selected who had at that time an abnormal smear without any follow-up within 12 months. Both the GP of the woman and the doctor who took the sample received an electronic reminder. And 1 year later, the evaluation of the fail-safe system showed that 69% of the women had a follow-up. The time between the follow-up and the reminder varied between 37 months before the reminder and 60 months after the reminder. We saw that 46% of the women, the follow-up took place before the reminder was sent. This means that these women were incorrectly selected and received a redundant fail-safe reminder, and these reminders were due to a late registration of the follow-up in our BCR databases. Now, if you leave out these redundant reminders, 42% of the women had really a follow-up after the reminder. Some issues about the lacking follow-up have already been identified. For instance, some women died shortly after the selection or moved abroad. Other problems are doctors who are no longer active, for instance, a retirement, or switched from working place, as is sometimes the case for trainees. And further investigation is still needed, such as checking whether the system for electronic reminders is sufficiently accessible for doctors and also really used.
So the close collaboration between the Center of Cancer Detection and the Belgian Cancer Registry creates unique opportunities in the screening program. We have a very efficient invitation system. We have a detailed monitoring and quality assurance. We are able to send tailored communication to non-attenders, and we have an adequate fail-safe system. We thank you for your attention and look forward to your feedback and questions.